Alrighty, so week 4, path immune disorders. So we have here our organs of the immune system, pretty straightforward. And the immune system itself is broken up into the innate immunity and the adaptive immunity. The innate immunity is going to be like our white blood cells, mast cells, macrophages, dendritic cells, NK cells, um, the things floating around all the time that kind of indiscriminately kill whatever doesn't look like a normal part of us. The adaptive immunity is going to be that slow response that builds up over time and prolongs long-lasting immunity. And that's divided up into the humoral or antibody-mediated immunity and the cell-mediated immunity. I don't know why I can't say immunity very easily. All right, and so when it comes to dysfunctions of the immune system, we can have either an excessive immune response or a deficient immune response. Excessive could be, for example, seasonal allergies. It can be either an autoimmunity issue or a hypersensitivity issue. And deficient immune responses, for example, would be AIDS. And it's where we simply don't have enough of a response. So with excessive immune responses, this is going to be for autoimmunity. We recognize something about ourselves, or the immune system recognizes something about ourselves as a foreign object that it needs to kill. And we can have environmental triggers like infection or toxin exposure that can lead to autoimmunity. We also have to have genes, an immune dysregulation, and an environment working together to create an autoimmune disease. So with a normal, all right, so that was autoimmunity. This is now hypersensitivity. For a normal immune response, in order for it to be hypersensitive, we need it to be inappropriately triggered. So for allergies, something that's not actually going to kill us for whatever reason, seasonal allergies creates this inappropriately excessive triggered response and produces undesirable effects. No one enjoys rhinorrhea or rhinitis. And we have a specific antigen-antibody reaction that occurs and usually does not occur on our first exposure. It requires multiple exposures to promote a actual immune hypersensitivity reaction. And when it comes to the 4 different types of hypersensitivities, there's kind of a special way to think about it. So first we have the immediate hypersensitivity. So this is going to be anaphylaxis, allergies, asthma. Don't worry about the mediators. These I don't think are important for the tests. So these are going to be very quick reacting, immediate reactions. Type 2 is going to be the antibody-mediated hypersensitivity. So this is going to be where we have antibodies actually responding to the issue. So a blood transfusion or a transfusion reaction are going to be the most classic symptoms or form of this disorder. The type 3 is the immune complex hypersensitivity. Complex is the most important part of this. What they mean by that is that we have actual antigen and antibody, Ig is standing in for antibody, complexes that develop in response to whatever this autoimmune issue is. Those complexes then get deposited in parts of our body, like for example in rheumatic diseases, like rheumatic arthritis. We're talking about actual complexes or the things causing destruction by being deposited into our joints, leading to inflammation and destruction at the joints. And then type 4 is going to be our delayed hypersensitivity. And this could be a transplant rejection that occurs slowly over time, contact dermatitis, poison ivy, things that take a while to respond. The way that you can remember this is we have 1, 2, 3, 4, and we have A, B, C, D. So anaphylaxis, allergies, asthma, antibody mediated, I know it starts with an A, but it's the B there. Immune complex, because it develops complexes, hypersensitivity, and then delayed hypersensitivity. That's how I remembered it. All right, So the difference between primary immunodeficiency and secondary immunodeficiency is that primary does not manifest as the result of another disease. It is on its own a primary issue. So this can be due to a congenital or genetic or acquired defect that directly affects the immune system. It can affect the B cell, T cell, both. Um, and the person who has a primary immunodeficiency will have severe, recurrent, and unusual infections. So severe combined immunodeficiency is going to be where we have a dysregulation or some sort of dysfunction to both T cells and B cells. So here we have a normal person on this side, normal immune system, creates T and B cells, they're able to fight infections. People with SCID have an immune system, but it's dysregulated because they don't make the T and B cells, so instead we have a decreased immune response and cannot fight infections. So this is where some people may have heard of this, bubble boy. He had to live inside of a bubble because he was so susceptible to literally anything that our normal healthy immune systems would fight off without much of a problem. And SCID is actually also a sort of an umbrella term for a lot of different types of primary immunodeficiencies that involve T and B cells not being produced in enough quantities. And because it is X-linked, or because most of them are X-linked, it leads to higher rates in males in general. Secondary immunodeficiencies are going to result from something following disease, or exposures, taking medications, having certain surgeries, radiation, cancer, potentially stress, I think that's what it was here, and potentially diet, I think is what that Slurpee is meant to show, can then lead to immunodeficiencies as well, but as a secondary immunodeficiency because you're acquiring it following a disease or a situation. All right, so these are going to be our acquired primary immunodeficiency. Yeah, I don't know how that works. Okay, HIV. We're just going to go in HIV. HIV. This comes from retrovirus, which is type 1 and type 2. What type 1 comes from Central Africa. And then this is going to be the one that causes most of the AIDS cases that we hear about throughout the US, Africa, whereas the type 2 is going to be the West Africa form of HIV and has a longer latency period and generally lower mortality rates and a milder effect. Type 1 also is what leads to AIDS. Okay, that's all pretty straightforward. The majority of these are going to be occurring in other countries, not in our country does not have as many, similar to TB. So where are we? Are we even on here? I know we have to be on here. I guess we're not. So we're not very high on the leading scale for HIV, nor TB, and they're both considered sort of, what's the term? They both happen together a lot. So HIV, most commonly is transmitted via sexual, not just intercourse, but through sexual contact. You can also do parenteral through blood products, sharing needles, or perinatal in that they get it from being born to a mother who already has HIV. So prevention occurs from abstinence, which abstinence programs don't work. Condoms, using them properly, not like my brother who unwrapped it and tried to put it on and found out it doesn't work that way. And serosorting, which is the intercourse choosing to only have sexual relations with HIV plus and other HIV plus. Right? That doesn't make any sense. HIV positive people choosing to have sex with only other HIV positive people because that way they don't transmit HIV to other people. Using sterile needles, which is really good and is also a good public health policy to try to get sterile needles out there for those who are who do have a substance use disorder, using and providing sterile needles prevents more transmission of deadly diseases. Universal precautions for us, post-exposure and pre-exposure prophylaxis. Let's see here. So I think we talked about post or PEP and PrEP in farm. So the people who are most at risk are going to be the men who have sex with men, people who have sex for drugs or money, sex with sex workers, as a John, for example, vaginal sex with high risk, or having multiple sex partners, as well as IV drug use in general, infants born to mothers with HIV positive diagnoses, and genetics, since some people have a natural resistance or susceptibility to HIV. HIV, though, is not transmitted by air or water. It is not that kind of a virus. Saliva, sweat, tears, and closed mouth kissing do not provide the medium for which HIV can be transmitted, but open mouth can be a concern if there are sores that are open inside the mouth. Anywhere where blood can actually accumulate, can lead to transmission of HIV. Insects and pets cannot transmit HIV, nor can sharing toilets, food, or drinks. You'd have to get very intimate with that toilet to actually have it transmit HIV or any other STI. Okay, that was the same stuff. So HIV, the way it works is we have an HIV envelope protein that specifically binds to CD4 receptors on T cells and macrophages. So they bind to it, and then they inject through the CD4 receptor, or then, what's that word? I just totally forgot that word. Phagocytize, I don't remember. They bind to it, they come inside. They bring their RNA and DNA into it. So let's go ahead and open this up a little more, make it a little easier. So the life cycle of HIV, and sorry this is blurry. So HIV binds to CD4 on the host cell. HIV then uses or injects DNA or RNA, reverse transcriptase, integrase, and other stuff into the host cell. The host cell then will form DNA from RNA with reverse transcriptase. Reverse transcriptase will then have, or not reverse transcriptase, the RNA, which then became DNA, will have integrase act on it to implant the viral DNA into the host cell's DNA. The host cell's DNA will then produce new viral RNA that can then be collected along with other stuff to create new virions. And the virus then matures by protease, releasing individual HIV proteins. And so it just continues on from there, and that's how we end up getting a wide number of cells or viruses into the blood very quickly. Or I guess it's kind of quickly. Yeah. Anyway, so the HIV replicates prolifically, overwhelms the immune system, causes cell death. The mechanism by which HIV actually destroys CD4 cells is unknown. There are some theories, but they don't necessarily really understand exactly how it works yet. This I think was important from what I recall. Most commonly replicates in the GI tract. So the replication process most commonly replicates or takes place in the GI tract. So we have 3 stages of HIV progression. We have the acute infection, the clinical latency, and then AIDS. So during the acute infection, there's going to be a large amount of virus produced in the body, and people are going to develop flu-like symptoms, which they may not even have any idea that it's actually HIV. They'll kind of recover from this and enter clinical latency, where they won't really present any signs and symptoms. The HIV virus will actually multiply at a very slow rate, and we hope to keep people in clinical latency indefinitely. We use medications to keep them in this period. Some people will progress faster, and anyone who falls below 200 millimeters cubed of CD4 in the blood will be counted as having AIDS. And they're going to be very susceptible to opportunistic infections and cancers. So when we have our acute infection, it's going to be flu-like symptoms, decrease in white blood cell counts, decrease in platelets, increase in erythrocyte sedimentation rate, which is just our systemic, non-specific inflammation count, and an increase in HIV viral counts in the genital fluids, one of the reasons why it's so easy to get it from having sex with someone who has HIV. And it's very infectious, even when the symptoms go away in 1 to 4 weeks. They're going to be infectious the entire time, regardless of everything. I mean, once you have HIV and it progresses to the point where you start showing any symptoms at all, you are able to be infectious. So testing for HIV, there are a number of options. The ones that are very common are going to be the ELISA Plus, which is I believe, a cheaper test, and it stands for enzyme-linked immunosorbent assay. If it's negative, that means the patient does not have HIV. But if it's positive, then they have a strong suspicion of having HIV, and they need to be confirmed with a Western blot test, which will actually detect the specific antibodies. I believe, as with most of these things, the reason why we don't go with the Western blot right away is that the Western blot is probably a lot more expensive. After they've been confirmed, we're going to do other testing, such as CD4 cell counts, to figure out how they are responding to treatment and whether they have progressed to AIDS. And then we're going to do testing for infectious processes due to susceptibility to infection. So when it comes to testing HIV, false negative results can occur before seroconversion, which means when the antibodies actually start to appear in the bloodstream. So we want to make sure that if someone's gotten exposure, if they have had some form of a significant exposure, we do test them right away. But then we also say, hey, come on back. I'm not sure what the time frame would be. Maybe like 6 weeks, come back, and we're going to have you tested again. All right, so some of the clinical manifestations are going early on. They may be completely asymptomatic during a latency period. Oh, wait, this is latent. All right, latent, they're going to be asymptomatic. They may experience some short-term memory loss, develop oral or genital herpes because they're not going to have much of an immune system to work with necessarily. They may develop oral hairy leukoplakia, which is going to be, it's kind of hard to see here, but it's these white lines on the side of the mouth here. It can't be scraped off. It's a benign issue, but it's a clear sign, or I think it's supposed to be like a classic sign of HIV. They can also develop skin rashes and flaky skin, viral or fungal skin infections, mucous membrane infections. And then for children who have HIV, they can develop or have growth delays and become frequently sick, as that occurs with anyone with HIV. So HIV converts to AIDS when, and this is by the CDC, when they have HIV and they have a CD4 T cell count of less than 200, or they have HIV and an AIDS-defining illness, which we'll cover in a second. Children will progress more often, more rapidly than adults. So some of the AIDS-defining illnesses or conditions are going to include, I'm not going to try cytomegalovirus. I'm going to try and do it right. No, wrong button. Cytomegalovirus retinitis with loss of vision, HIV-related encephalopathy, pneumocystitis, gyrovecchi, pneumonia. So I mean, clearly a lot of these things we've never heard of, and they're very specific to people with HIV. So TB. It could be pulmonary or extrapulmonary TB. Chronic intestinal cryptosporidiosis. I'm not going to bother. Invasive cervical cancer, Kaposi sarcoma, and wasting syndrome. So if a person has HIV and they don't have a CD4 count of below 200, but they have one of these AIDS-defining conditions, by definition, that would mean they have AIDS. So for Kaposi sarcoma, this is going to be something that occurs with herpes or with HIV, and I think occurs on a pretty regular basis. They can have mucocutaneous lesions where they have mucus. That's going to be the section where the mucous membranes meet the skin. So like around the lips, around the anus, around the eyes. And they can develop then these sort of little spots, either regularly on the skin or on those areas. This is AIDS specific. We can develop stuff on the skin, mucosa, lymph, lungs. So like this also right here, this really nasty thing, that is a indication of Kaposi sarcoma. I don't know exactly what that's called. I tried looking it up. It was not clear. So for our nursing implications for this, we're going to want to educate our patients on the idea that this is going to involve the entire body, and be aware to look for signs that they may not even be aware of that are part of the process as this goes on. Whether or not they are severe is going to be based off of where they are in the timeline, and certain people will develop certain symptoms and others won't. We want to have or promote HIV screening for anyone who has prolonged exposure, not prolonged, who have significant exposure, starting with the ELISA, then moving on to the Western blot. We want to start them on antiretroviral medications, which are going to be multi-drug therapies, aggressively treat infections since they're so susceptible. I don't have a clue what the peptide growth factors are. I couldn't find that in the book. And we have no vaccine because it's virtually impossible to make a vaccine for HIV at this point with the stuff we have. We also want to try to prevent transmission by educating our patients and providing them with resources to prevent transmission. We wanted to delay the disease progression into AIDS by encouraging them to be consistent and adhere to the treatment plan as well and clearly as possible, and minimize clinical manifestations, specifically with preventing malnutrition and wasting syndrome, so make sure that they're going to have plenty of food, and also just in general prevent the progression, which will make the manifestations worse. Prolong survival, straightforward. All right, other immune disorders, or autoimmune disorders. So type 3 hypersensitivities, this is going to be where we're going to have these antibody-antigen complexes. So these are going to be all of our complexes. These things will then get deposited somewhere. So this is a general issue. It's not tissue specific. It can happen in lots of different parts of the body. Let's see here. So the immune and phagocytic systems, for whatever reason, fail to remove these complexes from the system, and then those complexes get deposited in vessels or tissues, and they activate inflammation. And the inflammation becomes self-sustaining. We end up getting tissue destruction, scarring, and it's this cyclical, repeated cycle. I guess is what I just said 3 times in different words. Over and over again, creating more damage, more inflammation. Systemic lupus erythematosus and rheumatoid arthritis are going to be our prime explanations of this, or examples. So what we have is the immune complexes are deposited in the wall of blood vessels. So that's these 2 guys right here. And then the presence of those complexes will then activate these little complement parts of the immune system, which attract inflammatory cells such as neutrophils. The enzymes released from those neutrophils will then cause damage to the endothelial cell. So we see right here there's degradation all through that area. These little blue guys are supposed to be enzymes of the basement membranes of those endothelial cells. So that's an example of how this causes damage overall. So I guess we're going to a big picture view of arthritis here. Supposedly arthritis is the most common disabling musculoskeletal disorder in the U.S. We can have it based off of autoimmune disorders. It can be genetic, degenerative, infectious. Comes on more often as an advanced age, as sort of a natural part of aging, I believe it is. Not rheumatoid. Rheumatoid's autoimmune. But regular arthritis oftentimes comes with advanced age because of just the wear and tear that naturally occurs within our bodies. Some people do, unfortunately, also have it as an onset during childhood. Bouncing back now to RA, this is going to be a chronic systemic and autoimmune inflammatory disease compared to arthritis, which is more of a natural aspect of aging. And there are probably going to be genetic predispositions to it. Females are much more affected than males, 2 to 3 times that of men. And there is inflammatory joint destruction involving the synovial membranes, cartilage, joint capsule itself, and the surrounding ligaments and tendons. So it affects everything within a joint. So we have that autoimmune reaction of something, leads to the autoantibody complexes that then get accumulated in synovial fluid, leading to inflammation, granulation, or pannus, I'm not sure what that is. I think that was this big thing here. But basically all of this ends up swelling in this joint here from all the immune complexes and the immune response to those immune complexes. And then that leads to cartilage and bone erosion. So as you can see here, the bone here has started to become eroded, I think. Oh, and there's the pannus. All of that right there, that fun stuff, leading to destruction of this joint, mostly from inflammation. And arthritis, rheumatoid arthritis, usually affects symmetrically. So if you have one shoulder affected, you're probably going to have both shoulders eventually affected. And of course, we're going to have joint pain. A lot of times it happens to small joints. So joints of the feet, joints of the hands are very commonly affected. When people wake up in the morning, they often have up to sometimes longer or greater than an hour worth of morning stiffness. And anytime that they are stationary or sedentary for a prolonged period of time, like maybe on the plane for 6 hours, they're likely to experience more significant stiffness that lasts then for 30 to 60 minutes, sometimes more than that. We also have, I don't know how to pronounce this, Sjogren's syndrome, which leads to dry eyes and mouth. This can occur on its own as its own autoimmune disorder, but oftentimes occurs with other autoimmune disorders as well. We can also develop pericarditis and myocarditis from autoantibodies being deposited into the heart and then leading to like rheumatic heart disease. They're also commonly going to experience malaise and fatigue and depression from a lot of reasons. So for us, what we're going to do is we're going to try to treat our patients with NSAIDs, corticosteroids, and immune modulators. And we want to do this as early as possible because once damage occurs, there's no reversing it. So we want to try to prevent it progressing. We want to achieve long-term control of symptoms by starting early and maintaining that control over the life course of that person. And we want to try to encourage independent ADLs and maintain activity levels because when patients have rheumatoid arthritis, the more movement they do to an extent, the better because it helps to keep those joints warm and helps to prevent the joints from stiffening up and making them that much more discouraging to try to use later on. All right, systemic lupus erythematosus. This is a multi-system inflammatory autoimmune disease. So we're going to be hitting a lot of different things with this disease. They have exacerbations, remissions, and it is a rheumatic disease, which means there is pain and inflammation in joints, muscles, or fibrous tissue. Women are very I'm sorry. What's the word I'm looking for? Women are affected more often than men are, 7 times more than men. So the way it works is that we have genes and environment that can lead to an abnormal immune response. So that abnormal immune response then produces autoantibody or immune complexes similar to rheumatoid arthritis, and they then get deposited in certain parts of our bodies. So, for example, the kidneys, in the face. I believe there are other areas as well. So we could have it in the heart, for example, and we're going to lead to chronic inflammation and chronic oxidation, and we're going to have damage to our kidneys, to our blood vessels. We can then have renal failure, atherosclerosis, pulmonary fibrosis, stroke, damage from the prescriptions that we use. And this all comes from the B lymphocytic overactivity up here that leads to autoantibody immune complexes. So the most common symptoms of this are going to be like a low-grade fever and photosensitivity. They're going to be very photosensitive. So we always want to encourage using precautions when going out into the sun or just plain avoiding the sun. A butterfly rash is very common. That's sort of like a classic symptom of SLE. Ulcers, ashes, arthritis, joints, since it's also like a rheumatic disease. Those same complexes can show similar signs as rheumatic or rheumatoid arthritis. Pericardium, inflammation, we may get stuff pooled in there as well, and poor circulation through the fingers and toes due to accumulation within the blood vessels. When it comes to diagnostics, we're going to check with a anti-nuclear antibody lab. So 95% of SLE patients will have high ANA levels, but it is not specific to SLE. So we would need to make sure that we are confirming with other mechanisms, history, physical signs and symptoms, in addition to the ANA. We would be treating with corticosteroids, NSAIDs, immunosuppressants, immunomodulators, and prevent avoidance or going into the sun because we don't want to progress any cutaneous lesions by direct sunlight. We also want to assess and monitor renal function since these immune complexes are disproportionately, that's the word I was looking for. Women are disproportionately affected by SLE compared to men, not discrimination. So kidneys are disproportionately affected by SLE, and as are pulmonary functions. We may get deposits in there leading to pleuritis of some form, and then CNS function can be affected as well. I don't remember as much about that one. Discussion questions. Neoplasia. So neoplasia, it's cancer, basically. Means new growth, implies abnormal cellular growth. It's malignant when the cancer has spread, metastasized, and may not be survivable. It's benign when it's easily cured. And we can have a tumor, which is oftentimes a tumor is associated with a benign cancer. This is the second leading cause of death in the U.S., with most deaths occurring over the age of 55. Men have a 1 in 2 chance or risk of getting cancer. Women have 1 in 3, and 5-year survival rate 68%. So the most common cancers in women, breast and lung cancer. In men, it's prostate and lung cancer. And then the deaths switch so that it's lung and lung cancer is the most common to die for in both genders. And then breast and prostate are the second most common to die from among these genders. So more than 1/3 of cancer-related deaths are due to preventable factors. So tobacco, just don't smoke, it's bad. Not eating a nutritious diet with lots of fruits and vegetables, particularly vegetables. Supposedly being obese. I think it's more about the things that may have led to obesity, depending on what those factors may have been. Sun exposure, radiation, since radiation promotes cancer. Hormonal association. So if people are going on taking hormone replacement therapy, that is a risk factor for developing cancer. You can't avoid getting old, just accept it. Don't try using hormone replacement unless you need to. And then sexual exposure to HPV, leading then to cervical cancer. The earlier the screening, the earlier the detection, well, no, that's not right. Early screening can lead to early detection. Alrighty. So, benign tumors versus malignant. Benign generally does not kill the host. I mean, that's the definition. It does not kill the host, not generally, it just doesn't. But the location itself may be life-threatening. If you develop a tumor in the brain that is unreachable by surgery and it continues to grow, you got a good chance of being killed. If you got one that develops somewhere where we can't reach it and it blocks the throat, airways, you might die. They're oftentimes slower growing and they do not metastasize. There's very little vascularity, which can be it's a good thing from the perspective that they're not necessarily going to lead to metastasis very easily, but because they're also oftentimes encapsulated, and because vascularity is how we get drugs to something in the body, they can be very difficult to treat with drugs. And so we may have to be resorting to simply surgery to treat it. They're rarely necrotic, and they more oftenly resemble the original tissue type, sometimes even while being able to retain the original function of that tissue type. Malignant tumors can kill the host. They have rapid growth and they metastasize by nature. And they may initiate tumor vessel growth, making it possible to spread the cancer even further. Cat, get off. Yeah, you're cute. Let's see here. Stop. You can't, no, don't bite that. They're frequently necrotic. Okay, frequently necrotic. And they do not resemble the tissue type of origin. I don't know what that's saying. The greater the anaplasia, the more aggressive the malignancy. I don't remember that. Okay. So metastasis, we have our primary tumor becomes vascularized. Part of it breaks off. Angiogenesis is just it becoming vascularized, creating vessels. Hey, no. It's like a love-hate relationship with cats. All right, so they get vascularized, they detach, they go and squirt themselves into a blood vessel, start to circulate throughout the body, and they adhere somewhere, they go out of the blood vessel, and they start growing a second tumor somewhere else. That's the general idea behind metastasizing. There we go. So when it comes to nomenclature, oma means a tumor or abnormal growth. An adenoma is normally benign and grows in glandular tissue. Carcinomas develop in epithelial tissue. Sarcoma can be growing in the nerve, bone, or muscle tissue. Lymphomas grow in the lymph nodes. Hepatic is going to be liver. And melanoma is the skin and involves the melanin-forming parts of the skin, or those cells. And then leukemia is going to be white blood cell cancers. So hallmarks of neoplasias are going to be that they are self-sufficient in growth signals, so they can continue to promote their own growth without having signals from anywhere else. They are insensitive then to anti-growth signals, so they promote their own growth. They don't respond to things telling them to stop it. They have the ability to invade tissues and metastasize. They have limitless replication potential, and I believe the reason for that was because they are actually able to replace or renew their telomeres on the end of chromosomes, making it so that they can just limitlessly replicate, which would be pretty awesome if we could figure that out and use it for ourselves. And they have then sustained angiogenesis, so they have great blood supply, not always, but they have good blood supply depending on the kind of cancer it is. And then they can evade apoptosis, the natural way that our body uses to destroy cells. There's all around nasty. A carcinogen is anything that can potentially cause cancer, and there's a whole host of things in smoking or cigarettes that can cause cancer. Just if you are smoking, do your best to get off of it. It's terrible for you, and just don't even ever try smoking if you've never done it. Just don't. When we have, so in our normal genes, we have a tumor suppressor gene somewhere in there. Normally, it creates a normal growing or normal growth inhibiting protein that keeps cell division under control. BRCA1, BRCA, I don't know how people get BRCA, but it's BRCA, is a tumor suppressor gene. And normally, tells stuff, quit it, knock it off, stop growing. Sometimes, in certain people, the BRCA1 gene may be mutated. And so for this particular, when that becomes mutated and develops this defective non-functioning protein that doesn't do a good job of getting the cell division under control, then suddenly we have a high potential risk for breast cancer. And I think it was like 70 or 80% of women who have BRCA1 mutations are going to have breast cancer by 60 or 50 years old. I don't remember exactly. And these genetic mutations can be acquired or inherited, but they're more oftenly acquired. We also have proto-oncogenes as a way to try to regulate our cell growth. The proto-oncogenes are the normal genes, and they signal cell division, and so they help to get things going. They can also help to regulate apoptosis, and if they become mutated, they will then become an oncogene. So the protogene is good. The oncogene is bad. That proto-oncogene is then a mutant overactive form of the proto-oncogene, and this can contribute to cancer. And it stimulates constant, unrelenting cell proliferation. So it's just going nonstop. The mutation is not usually inherited. It's not like you get a already mutated proto-oncogene into an oncogene. It normally develops over time from exposure or something internally. So for example, like chemicals, the sun, radiation, infections, those can lead then to a transition from proto-oncogene to an oncogene. And when it comes to the development of cancer, we typically need to have both an oncogene, the bad version, and a defective tumor suppressor gene to create cancer. I really don't like this. This was made by, what study was that? I don't remember which study it was, but I really don't like it because that's not how a car looks, and those pieces in it are not clearly explained. That handbrake is in the exact opposite position, and that makes it look like it's already going. I don't know why they made it the way it did. The general gist of what they're trying to say here is that you have a car, and normally with a car, you have the tumor suppressor genes, which are like the brakes, and we have a proto-oncogene, which is the gas. And they're supposed to work in harmony to create cell division and then slow cell division. Everything's golden. When we don't have a proper, or when we have an oncogene, that oncogene is going to act as if it's pressing on the gas pedal at full force, and it will never let up. The tumor suppressor gene can still kind of work somewhat while the active oncogene is going on. But then, if that tumor suppressor gene gets mutated, then there are no brakes. That active oncogene is throttling the accelerator, and suddenly we go crashing into the cancer wall. And that's kind of how it works. The oncogene's a gas pedal, the tumor suppressor gene's a brake pedal. So we have phenotype and genotype. Remember, this is just a little review. Genotype is the genetic makeup, the actual chromosomes that we have, and phenotype is how and which ones manifest to make our external appearance. This didn't quite understand this one. It was not in the book, but I'm guessing that we have 3 stages of neoplasia development. We have the initiation, where we have a normal cell with a carcinogenic exposure via chemicals, radiation, or a virus, other stuff. Leads to initiated cells having, I guess they just kind of create some funky cells that have cancerous potential. And then we have promotion, where we have the pre-neoplastic lesion with a genetic change going under reproduction. This is the promotion center, and this will then turn into cancer. And then progression is when we have a malignant tumor that is metastasizing to other parts of the body. I don't think these 2 slides were necessary for you guys to memorize. They were not for us. But we have the ability to grade and stage neoplasias, going from normal, small, uniform, tightly packed. Actually, I think that's just regular cancer. Not normal cells, but it's not horrible yet. And then they're slowly becoming more differentiated into various types of cells, becoming irregular fused cells, and then irregular fused, and are just going everywhere. The greater the anaplasia, the greater the malignancy potential, and I believe anaplasia was difference in types of cells. I looked it up real quick. So the greater the anaplasia, or the greater the lack of differentiation, as I just found out, the greater the malignant potential. So the more that cells will become less different from each other, the more they no longer abide by the natural sort of design that they're meant to stay in, as well as their own shape, function, the more likely they are to become malignant. All right, so for staging, we have stage 0 through 4, which really bases off of how metastasized a cancer has become. Manifestations depend on location and extent of metastasis. Early may be asymptomatic. These are all pretty straightforward. Unusual bleeding, discharge, blah, blah, blah. And then other ones, these are supposedly for children. For warning signs, these are pretty straightforward. Clinical manifestations, the pain is going to be common and feared for cancer. It comes from metastasis, inflammation, can also come from treatment. Cachexia is going to be the overall weight loss and weakness that comes from a hypermetabolic state, and is theorized to have come from tensor necrotic factor. Did I say that right? Tissue necrosis factor. And other pro-inflammatory mechanisms as well. That's kind of the theory at this point. They also may feel a lack of desire to eat and have nausea and vomiting, which may lead to a lack of desire to eat. And then the immunosuppression that occurs also comes from potentially both the chemo that we give them and from cancer cell secretions themselves. We also have bone marrow suppression, which can come from or lead to then anemia, pancytopenia in general. Prevention and therapy, surgery, radiation, drug therapy to kill rapidly dividing cells. Stem cell transplant still has some potential in the future for being used to treat cancer. Immunotherapy would be helpful. And then targeted molecular therapies. Sometimes we can't do anything though, and we treat them with comfort care and hospice and palliative care.